Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help. Today is March 24th, Tuesday. We have a lot of updates today, so we're going to talk kind of quickly. We have a lot of updates for our patients. We have Dr. Bright here with us for a testing update, but we're going to start, as usual, with an update from Johns Hopkins and other sources as well. As far as locally in the United States, there are over 48,000 cases, around 592 deaths. This represents a 13.5% increase in cases and a 25% increase in deaths from the previous day. Again, just to reiterate, the increase in cases is going to be a little skewed depending on the amount of tests that are performed, but the death number is probably a better number to follow for how bad things are, and that 25% increase is a big number. It's a worrisome number. The case fatality rate right now seems to be around 1.27%, similar to previous days.
Yeah, and then globally, the big news is that Italy has been reporting pretty staggering cases in healthcare workers. So in some communities, there's been up to 25% of the physicians infected. And nationally, we know that about 10% of the overall cases are actually in healthcare workers. Epidemiologists are actually suggesting that the hospitals in some places are functioning as sort of the epicenter of the outbreak. Basically implicating that physicians or nurses are walking around seeing patients and transmitting the disease back out into the community. And this is frankly scary, and certainly the topic of conversation at my hospital last night among the physicians. You know, I think healthcare workers in general, and at least the ones that I've talked to, are quite nervous, and many of them feel like they don't have the PPE supplies that they need. So just another opportunity to say thank you to the people on the front lines who are bearing the brunt of this fight.
Yeah, two things about that. We recorded a podcast with Dr. Brian Atkins on PPE, potentially homemade solutions and other issues and how to conserve. We're releasing that, I think, tomorrow or the next day. So listening to that if you're a healthcare worker. Also, these death rates, I mean, the thing that we're not talking about is even though we had a 25% increase in deaths from the previous day, I literally worked a night shift last night and had 2 deaths of elderly patients who were respiratory illness, and those will not be reported in the numbers. I mean, we're not testing patients who come in coding, and in my mind, I was working in a place where it's very rare to get a coding patient, and there's 2 last night which aren't going to be counted. So these numbers, we're not trying to scare you with these numbers, but we're just kind of stressing the importance of all the social distancing that is happening right now. It really matters. We're seeing this on the front lines every day.
And in some other announcements, we have built a Wild Health internship program with everything that's going on with COVID-19. There is a ton of information being released every single day, and it's difficult to sort through all this information. And we want to keep it as accurate and actionable as we possibly can. So we're launching a pretty massive response and have some pretty cool projects underway. We've built a team of smart, hardworking individuals, but if anyone is interested in helping, we would love for you to join the team. We're looking for people, particularly in the medical field, like physicians, nurses, medical students, nursing students, nurse practitioners, or PAs. If you are interested in donating your time and efforts, please contact Matthew Gomez at wildhealth.com. Again, that's Matthew Gomez at wildhealth.com.
And just to spell that for you, there's two T's, MATTHEW.GOMEZ at wildhealth.com.
All right, let's talk about some patient updates. The first one I've got is fairly quick for all of our patients. Most of them have Oura Rings and to monitor their sleep, and they've actually partnered with University of San Francisco on a project to try to help basically diagnose and look at some of the Oura Ring findings from patients with COVID. So I'm asking all of our patients and anyone else who might be listening who owns an Oura Ring to open up your app. At the very top, there should be a button where you can click on and join the study. If not, you can actually go to Oura Ring, that's OURARING.com, and you can sign up at OuraRing.com. If you don't own an Oura Ring, you probably should, and you can go back and listen to one of our 15 podcasts about wearables and sleep tracking. But this is a great opportunity to help out the scientific community and try to figure out how else we can we can diagnose this disease and get more data regarding the infection.
And if you didn't listen to the podcast by Dr. Mike Stone and Mike Mallon within the last week, they specifically talk about how you can use your Oura Ring to monitor your temperature, HRV, resting heart rate. And we're not diagnosing this. The University of San Francisco, they're not going to be diagnosing, calling and saying you have COVID, but an early detection option, just more information for people. It could be really interesting. We have no idea how useful the data is going to be, but it seems like it could be some really valuable data. Also, if you're one of our patients, we hear you. During the COVID-19 pandemic, everyone has not just a health care burden, but a financial burden. And we want you to focus on your health. For our patients, for the next 3 months, the cost of precision coaching has been reduced by 50%. This is not a long-term viable thing economically. So this is not a long-term thing, but for the next several months, at least, we're reducing that cost by 50%. So follow up with your health coach or us about that cost reduction to you.
Yeah, let's move on to some literature updates. Mike, do you want to start out?
Sure. So the first one that I wanted to talk about is some more good news along the lines of warmth and humidity. This was a review out of the annual review of virology, and they were looking at the seasonality of viral infections. This was released on March 20th, and they specifically discuss CoV-2. Basically, the entire article, which is quite long, goes over all of the reasons why a lot of these viruses are more infectious in the winter than they are in the summer. And they do a really nice job of explaining the process by which they're more infectious. And it really breaks down to the fact that humidity and temperature make a big difference in terms of the virus's actual ability to live in droplets and its ability to infect you, because the colder things are, the worse the cilia inside your lungs work. So the mucus inside your lungs gets more sticky, it gets less hydrated, and basically viruses and bacteria can stick to it a lot easier and get down into the cells lining your lungs. So the overall take-home point for this article, I think, is that relative humidity of 40 to 60% helps inactivate the virus and allows for the best immune function within the host. In addition to that, temperatures have a good bit to do with it. So when the temperature gets below 68 degrees, we're seeing reduced ciliary function. So if I took anything home from this, I would suggest that you should have a humidifier in your home, and you should keep your home probably at around 68 degrees or potentially even just a little bit warmer to help reduce the likelihood of infection. Obviously, you can't control what the temperature is outside. You can't control what the temperature is at work, but this is helpful information for improving your likelihood of not contracting the disease. The next article is an interesting one, which is related to transmission. This one is substantial undocumented infection facilitates the rapid dissemination of novel coronavirus. This was released in Science on March 16th, which is, for all intents and purposes, a decade ago with the speed at which we're looking at research. This one passed my radar last week, and I wanted to bring it back to the forefront because I think right now is an extremely important time for social isolation in the United States. They estimated that 86% of all the cases in the early Chinese cohort were basically undocumented and never got tested. And that of those cases, the people who were undocumented and untested were likely asymptomatic. And those people, because they were asymptomatic, likely had a lower transmission rate. So probably only a transmission rate of about 55%, which is anywhere from a half to an eighth of the transmission rate that we're seeing with the symptomatic patients. So it makes sense. You don't have symptoms, you release less virus particles, you're less likely to infect people. But because there were so many of these asymptomatic patients, they likely represent about 3/4 of all the infections. So this concept that there are asymptomatic people or mildly symptomatic people walking around on a daily basis that are infecting others appears valid based on this single study that was released in Science on March 16th. So it really is important that even if you feel well, you're not out in the community infecting other people, and it really does back the argument for social isolation.
Yeah, and just to put a fine point on that, we talked about the number of deaths in the United States, and from this study, we could estimate that maybe 75% of those people who are dying are catching it from people who do not have symptoms. So I think some of the images we've seen on the news of people crowding into places and having a great time with this is going on, we just need to think about this. 3/4 of the potential infections and deaths are from people potentially just having a good time. So again, not to beat you over the head with the social isolation, but we give you these numbers because it matters.
Yeah, and the next article is an update from JAMA that was released yesterday. It's titled Case Fatality Rate and Characteristics of Patients Dying in Relation to COVID-19 in Italy. Basically, what this article does is it reviews the fatality rate as the numbers of deaths in persons who tested positive for SARS-CoV-2 divided by the number of SARS-CoV-2 cases, and identified the overall fatality rate as 7.2%. At the time that this was published, that's 1,625 deaths and 22,512 cases, meaning that the fatality rate was 7.2% as of March 17th. I think this really lends something that makes sense of these numbers. We've kind of guessed as to why the death rate in Italy is so high, but this study goes into it, and it attributes 3 factors as to explain that high death rate. Number one is the average age of the population in Italy is much higher, so we know that. Number two, but also the definition of COVID deaths does not account for other comorbidities. So again, aging population, lots of comorbidities, makes a lot of sense that these individuals are going to be affected a lot more than healthier, younger population. Finally, the testing strategies. I think we've kind of tied into this a couple times, but if you're not testing enough people, it's going to skew your data, and it's going to look like a lot higher mortality rates just because you haven't identified the total number of people who are actually affected.
It's interesting that they didn't comment on the fact that the healthcare system is overwhelmed there. I mean, that seems like a likely etiology of the increased death rate as well. I mean, we've all heard the stories of, having to make the call about who gets the ventilator and the double ventilators, basically treating 2 patients with 1 ventilator. It seems like that to me would explain some of it as well, right?
Yeah, we're totally speculating now, but they did not flatten the curve. They've got a spiked curve compared to other places, and this could be what that means. If you got a flattened versus a spiked curve, the fatality rate in Italy versus the fatality rate in other places. Again, that's kind of speculation, but that makes total sense. We do only have about 14 minutes until we're supposed to be recording a podcast with Dr. David Sinclair. So I want to bring Dr. Taylor Bright in to give us some testing updates. While Taylor is coming over, we do have a couple patient questions. The first one is, how does pregnancy affect COVID-19? Now, I'm not going to answer that right now because I'm recording a podcast with a couple OBGYNs tomorrow. It's going to be a dedicated podcast because it's a question that we're getting a lot, and it really matters and is really important. The second question is, if kids have been exposed to upper respiratory tract infection symptoms, if a kid is coughing and has any of these flu-like symptoms, can they visit grandparents after they've been isolated? I mean, again, I'll point you back to the number. 3/4 of spreads are by people who are asymptomatic. So a symptomatic person, when this is the dominant strain that's going around, I would say no. I mean, everyone's going to make their own decisions. We're making tough decisions and tough trade-offs, but I think the risk is much higher than the benefit of the kids seeing the grandparents during this time if kids have symptoms. So, Dr. Bright, thank you for joining us. Testing is a big issue. It's continued to be a big issue. So I just want to ask you a few questions really quickly. We all saw the news the last few days about the emergency FDA approval of the test. That's a really quick kind of 30 to 45 minute test. That's the machine that we purchased a week ago. We were assuming you'll get FDA approval. Do we have any updates on that machine and being able to utilize it?
Yeah, so currently those machines are being directed by the FDA to areas of highest need, New York City, Seattle, the Bay Area, other areas where the infection is really starting to take hold. So at the moment, our machine is not in yet, again, because it's being directed to those areas of highest need. But as soon as it arrives, now with the FDA emergency use authorization for the SARS-CoV test on that machine, we'll be able to get that up and running as soon as it arrives.
So we didn't know that would happen, but we knew anything could happen in these circumstances. So that's why we kind of were working with a backup route, which your lab is currently working on spinning up the CDC approved testing, just increase capacity as well. So can you give us an update where you are with that test?
Sure. And, as you noted, we have 2 or 3 backups right now because the one word to sum up testing across not only what we're trying to do, but across the nation here is shortages. So the CDC test is also working, or we're struggling with shortages of key reagents. We're doing our best to bring those in. We're doing our best to use our scientific knowledge to bring on alternative reagents that can help us get up with testing. Now, to be fair, those are not at the moment officially FDA approved, but they are in the pipeline, and we're bringing those online. And as well, we're doing our own research. We're doing research to bring on new fast-acting tests that can hopefully also contribute here to alleviating some of the testing burden. So at the moment, we're still waiting for some clinical grade reagents. We have the test in our lab. We're running it on control samples. But at the moment, we are waiting for more reagents to come in, again, as they are being directed to those areas of highest need. So we still think we're on track late the first week of April. But until we get some of these shortages worked through, and that's not only reagents, but also PPE shortages. Being able to collect samples for the tests is also being hampered by shortages of PPE to protect frontline workers taking those samples. So we're working through it as best we can.
So the answer to this question is probably no, but I have to ask, with the supply shortages that we're seeing now, is there anything that people can do to help that aren't in the medical field?
No, not really. From a PPE perspective, if you have any PPE, donate that to your local medical facilities. We've seen a lot of great work by individuals even making some PPE, and those do the best they can. But from some of these critical clinical grade reagents where we're looking at highly specialized enzymes. The companies that make those are spinning up production as fast as possible. They're getting federal grants to do that. And so we're just waiting for capacity to catch up.
A question that I'm getting quite a bit, Taylor, is, and I've got an answer to this, but I think you're better situated than I am to really answer it. So I'll ask you, how long is it truly going to take to develop a vaccine for this?
So in my opinion, assuming a vaccine can be developed, i.e. assuming that we will be able to make a neutralizing antibody response to this virus, I think we are in that 18-month time frame. I think there is a chance that something falls out of the tree, we get lucky, and we have a nice vaccine show up. The best example of this from a vaccine we use daily is the yellow fever vaccine. That was a random mutation seen in the lab in 1937, vaccine we still use today. So something like that could happen. But from a perspective of designing a vaccine against a coronavirus, to which heretofore vaccines have not been that effective, making sure it's safe and making sure, most importantly, that we don't get antibody-dependent enhancement of the disease. That's when antibodies that we create actually facilitate viral infection. Which is something that can occur. So I think from a safety perspective, we have some time. And then also remember, not only it's creating the vaccine, but then scaling it up to production. We also need to start producing seasonal flu vaccines over the summer as we move forward. So we have a production issue and we have a scientific issue. So I think we're in that 18-month time frame.
So to quote Lloyd Christmas, you're saying there's a chance.
I am saying there's a chance. Every day there's a chance.
All right. Yeah, not exactly what I wanted to hear, but I think that's the most honest answer we have right now. Taylor, with all of your knowledge, you have a lot of insight into what's going on. You're talking to us who are on the front lines, and with your background, PhD in infectious diseases, what are you doing differently right now that you weren't doing a month ago?
Well, the easiest answer is viral testing. We had a whole lab spun up for doing other clinical grade testing, and so we have, as quick as we can, obviously shortages notwithstanding, which we discussed, we have spun that up, and we've had a lot of great support from the community here in Lexington, getting new equipment that we need, and getting the access to the facilities that we need to get that going. Additionally, things that we're doing differently are the same things that everyone else is doing. We are doing our social distancing, keeping things, trying to do our best to limit spread while also staying out there and contributing as best we can. So everything has changed for everybody, and we're no different.
Can I tell you a couple things I'm doing differently? They're kind of embarrassing, but since nobody else is listening. So I've always had this not always, but in the last few years, I felt like a lot of our hygiene practices probably are more harmful than beneficial when it comes to disrupting the skin microbiome and things like that. So I have to admit, I haven't used a lot of shampoo in the past couple of years, or at least used very mild detergents. But I am definitely have stepped up the antimicrobial and antiviral and just intensity of the shampoo and soap. Also, I think in general, a lot of the deodorants that we have are could potentially be more harmful than helpful with some of the chemicals. So I've used very mild ones in the past, but we've gotten to a point to where my sweat smells worse if I'm stressed out. And during this time, I've actually started wearing more deodorant.
Sid, we are quite close right now, but coronavirus has caused a lot of changes in everyone's life, Matt. So
yeah, the risk-benefit ratio of soap and shampoo has changed quite
dramatically,
recently. All right, so from a light note to a slightly less light note, we've looked at a lot of models. What is the kind of worst case scenario if we don't take this seriously? I haven't really asked you this question, but looking at the different models that came out from the Stanford and other places that are modeling this, what are we looking at if we don't take this seriously?
So I'll talk about the worst case scenario, but I would say we have already started implementing many social distancing and quarantine, and we're doing our best to get testing up. So we are already doing our best to start to flatten the curve. But the worst case model that we've seen, Imperial College of London is probably the one that has made its biggest splash, but many individuals that I chat with have done very similar modeling, shows a peak around mid-June, maybe early June, and assuming no interventions, we're looking, somewhere in the order of 2 million deaths. We are working our best to bring that down. So it truly is the worst case scenario, but it does underscore the seriousness of what we're working with, and that the sacrifices that are needed to make are worthwhile.
And I think that number could just be a number unless it's got some perspective. Annually in the U.S., we have about 600,000 deaths from cancer. So do you know someone who's died from cancer? So this could potentially be 3 times worse. So I'm very happy that our leaders are taking the steps that they're taking. It's creating some pain economically, socially, and other ways as well. But again, these models are just that, models, but very smart people who have no real incentive to scare us are giving us these guidelines that say, hey, this matters, like we said 100 times on this podcast.
And I mean, just to underscore real quick, I mean, if we reduce the infection rate, the R naught number you all might seeing, just in half, from 2.5 to 1.25 per 5-day period, each individual goes from infecting 244 other individuals to infecting 4. Right? I mean, that is a dramatic increase. It just shows you when you work in a log space world, it's a very different world. It's very difficult to understand. But those are some numbers: 244 to 4, just by decreasing that reproduction rate by half.
Yeah, and to kind of spin that from a negative to a positive, because we got to talk to Dr. Sinclair here in 3 minutes now. There has probably never been a time in your life, if you're listening to this, that what you do in the next 2 to 3 to 4 weeks is going to make more of a difference. Like, you are literally saving lives if you do your part. So think of this in an empowering way, not a scared way or not a frightened way, but no matter what your job was before, no matter what you were doing, you can actually make a big difference with those numbers that Dr. Bright just gave to you. We all have to do it together, though. Thanks for listening. We'll be back tomorrow morning with another podcast and answering more of your questions in depth.
Thanks so much for listening to this COVID-19 update. Please send us your questions or follow along on Instagram and Facebook at Wild Health MD. And just to be clear, this is not medical advice. No patient-physician relationship has been established, and this resource is really for general informational purposes only. And finally, if you want to spread the word, please send this podcast to friends and family and give us a review on iTunes. Thanks again, and stay safe.